We're going to get ready to go ahead and transition right into the next panel that is going to focus on evidence-based models that work. And as you can see, the stage is full, and it's really exciting for them to see them together because it shows us that there is work being done in this space. And so I'm going to call to the stage Ms. Amy Robbins, who is our moderator for this session. And as she comes, Amy is the Senior Director of Policy at PHI. She is responsible for designing and leading PHI's historic and growing nationwide policy approach rooted in research, advocacy, workforce innovation, and public education in support of direct care workers. In her current role, Amy promotes federal and state policies and other initiatives to improve compensation, training, and a range of opportunities for the direct care workforce. Welcome, Amy.
Thank you. Well, panel one certainly brought it. So panel two, we have our work cut out for ourselves, but I think if I can get up here, we're up to the task. So I'd like to invite the panelists up to the stage, if you would. And I just want you to know that it's a struggle to put their accomplishments into a couple of sentences. I encourage you to look up more about the work that each one of these individuals is doing. It's really incredible. So I'm excited to dig in with you all on evidence-based models that work. So I'm going to go a little out of order here. But if so, you just raise your hand when I introduce you. Dr. Tina Satarangani is an NYU professor, a nurse practitioner, an NIH-funded clinician focused on improving care for people with Alzheimer's disease and supporting family caregivers, especially in immigrant communities. Her work centers on strengthening the connection between direct care workers and families. She leads innovative research on adult day centers and elder care systems and developed CareMobi, a mobile platform that connects adult day center staff with family caregivers to share real-time updates on daily health routines and progress. She also initiated, I'm sorry, I really tried to make these short, but it's hard. She also initiated the Enlightened Caregiver movement to help families navigate complex healthcare systems. Her work has had national impact and earned recognition in both academic and public spheres. So welcome, Tina. I'm also a caregiver. We should start there, right? All right, Dr. Courtney Van Houtven, yes, is a Duke University professor. I also noticed you were educated at University of North Carolina, and so those are fighting words in my family, to be at Duke and University of North Carolina, maybe others as well. A Duke University professor whose work focuses on aging, family caregiving, and long-term care. She has implemented caregiving interventions like high fives nationally in the VA to improve outcomes for both caregivers and care recipients. And recently, she launched a National Institute on Aging and NIH, National Institute on Health, study evaluating how self-direction and paid family care affects person-centered outcomes of Medicaid waiver participants with intellectual and/or developmental disabilities. Her research aims to better understand and strengthen support systems for family caregivers across healthcare settings. So welcome, Courtney. Dr. Karen Steinway is an assistant professor of pediatrics at the Zucker School of Medicine at Hofstra Northwell, licensed social worker and health services researcher dedicated to improving care for individuals with chronic conditions and disabilities, with a focus on youth transitioning from pediatric to adult healthcare. She leads multidisciplinary research and oversees major grant-funded projects combining social work and public health expertise to develop her patient-centered care coordination models. Her work emphasizes collaboration across patients, families, and healthcare teams to drive meaningful and sustainable outcomes. Karen. Dr. Matan Shukman is a geriatrics specialist in Baltimore, Maryland, dedicated to advancing care for homebound older adults and families who support them. For the past year, he's been the medical director of the Center for Successful Aging in Baltimore, which includes both a clinic, assisted living, and house call practice. Previous to that, his clinical practice was in house call medicine for older adults at Johns Hopkins, where he was medical director for the home-based medicine program. His research has been published in the Journal of the American Geriatric Society and the Journal of Applied Gerontology, focuses on improving the well-being of family caregivers of multi-morbid, homebound older adults, as well as innovative educational approaches to house calls. Dr. Kalisha Bonds-Johnson is a neuroscientist, clinician, and advocate dedicated to improving the lives of African-American individuals living with dementia and their families through research, clinical care, and education. As an assistant professor at Emory and principal investigator of the DECIDE Research Lab, she leads efforts to develop culturally responsive programs that enhance quality of life and communication with healthcare providers. Her work is contributing to broader national change in dementia care and health equity. Welcome, Kalisha. There you have it, you guys. Wow, right? All right, so we're going to jump in here. So just to kind of sum up who we have and the expertise that we're going to try to pull out in the course of this conversation. We have some disease and condition specific expertise. We have folks who are working on Alzheimer's care, working in the IDD space. And we have folks who are focused on culturally responsive care, thinking about immigrant communities as well as communities of color. And we have a variety of populations that are being focused on, from youth, again, to IDD and developmental disabilities, as well as older adults. So really quite a spectrum, very comprehensive expertise here. So I got to change where I am now. Somehow. There we go. All right. All right. So one of the interesting things about the relationship between family caregivers and direct care paid caregivers is that it often happens at home, behind closed doors, right, in private settings. It is extremely individualized and personal. And so I'm really interested in this first question that we have in thinking about success. What does it look like? And how do you think about that in the context of evidence-based models and extracting from these relationships that have so many different elements to them? How do you extract out what's really working and what perhaps can be applied, in a more generalized kind of way? So we're going to start with a pretty broad question, and you'll each have a couple minutes to provide your kind of insights on this. But as from your perspective and from your work, what defines success when you're talking about the intervention to support shared care between family caregivers and direct care workers? We can go in whatever order you want, but maybe we'll just start with you, because I'm always right. So
Okay.
It's just this little button right there. Slide it over.
Okay, thank you. Oh, such an honor to be on this panel. Thank you all for having me. Again, I'm Matan, I'm a geriatrician, and I work in Baltimore City. And for me, defining success in this shared care paradigm is all about having our care recipients be able to stay at home and stay at the community. In the community, I think that is the primary outcome that I think is most important. And I know that's a complicated outcome, and a lot of things are tied into it. It's about avoiding hospitalizations, avoiding the emergency room, which are often the gateway to going into the cycle of SNFs and long-term care. And it's about supporting our caregivers because the quality of care that individuals receive at home, and I don't have data, I'm sure there's data experts here that can back me up, but just in my personal clinical experience, that's the number one determiner of how well that individual is going to do, is how much support and how the quality of the support that they're receiving at home. So keeping them there, I think, is the best.
You're just gonna go down.
Yeah,
So thank you again for having me. I'm so happy to be here today. Again, sort of a lot of the work that I do focuses on folks with intellectual and developmental disabilities and their family caregivers. When we think about sort of our definition of success, we sort of think about it in two ways. The first is really making sure that the goals and the sort of like overarching quality of life of the person with a disability is at the forefront of whatever decisions are being made in the context of that shared caregiving. And so focusing on first understanding what the needs of that individual are, what their desires are, what their hopes are, being able to capture that in some type of meaningful way and track that over time. And then again, sort of help align that those caregiving responsibilities with what that individual wants. The second is really thinking about sort of like the caregiver's experience, both in the context of their caregiving, but also in the context of the way in which they're interfacing with a variety of healthcare or other services that are being provided to that individual. So we think a lot about how we can decrease caregiver burden or caregiver stress associated with that caregiving responsibility. And again, making sure that whatever intervention we're trying to develop gets at that as well.
I think that sometimes we think we let the perfect be the enemy of the good when we think about what is successful intervention. I just want to give an example from the VA where I used to work and worked for 20 years. We had a family skills caregiver training that really elevated home time. So ability for the veteran to remain at home as our primary outcome. We also agree with that being at home is best and wanted to test that. But we found that it didn't improve home time, and yet our operational partners really loved the fact that what it did increase was satisfaction with care, both from the veteran who didn't get touched by the training, but also by the caregiver. And so they really saw a gap in the system that this caregiver skills training could fill, and they were willing to invest in it and help us implement it nationally. And I want to just mention that this caregiver skills training was offered at a time when the care needs were changing. It was for caregivers of veterans who had home health care referrals and were about to have help in the home or were already getting that help in the home. And I think the thing that made it successful in that sense is that it really helped caregivers face some ideas about those increasing needs in terms of thinking about what's going to happen next. What do we need, maybe a transition to nursing home eventually, or even transition to hospice? And how can we partner with the home health aides to really think about shared decision making? And I think one of the key things that was successful about that intervention is it came at a good time, and it also helped people not feel alone and not be failed by the system. So that's just a perspective I wanted to add, that as researchers, we often think like our trial failed and we can't implement this, but I wanted to say like we were able to really implement that at 140 sites nationally because the care recipients loved the training, the caregivers felt like they were in a part of the system and recognized, and the VA thought it filled a gap in skills training. So just throwing that out.
So I recently was at a conference and somebody from a community agency called Care in Kind pointed something out to me, which is that from a caregiver's perspective, the one outcome we should be measuring that we're not measuring enough is relief. Does this thing, this training, this app, this, whatever it is you created, how does that provide relief to this person? As a clinician, I don't think, despite all my years of training until it was my father who was sick, that I realized there was this weight that lives on your chest when you have a loved one. And it's a weight when it's your patient that you can put away, but when it's your loved one, it is with you constantly. And how do we create something, and I happen to be in the age tech space. I created a mobile app, but there's a saturation of apps. There's 1.5 million apps and technologies and everything. Now we're going to replace caregivers with chatbots. Yeah, right, give me a break. But I think but my point is that there's so many of these things get abandoned because they're another thing. And we can't create models that are another thing. We must create things that bring relief, and we must be actually measuring that.
I love it. I'm friends. I will just say, I had a couple ways I was thinking about success. As a clinician, I think the one thing I really care about is everybody being heard, especially when you're dealing with underrepresented groups that are often not brought to the table in any aspect. We're not even brought in the room, let alone at the table in which most people are sitting. And so wanting people to feel heard. So have I called DONs? Have I called individuals in nursing homes in a clinic visit? Are they on speakerphone? Have I had family members on speakerphone in visits? I have. Do I have direct care workers sitting in visits with me? I do, because I work at a dementia-friendly primary care practice, where if the person living with dementia comes in without someone else, I'm like, wait a minute. Hello, wait, you can come up. We have a couple with my cognitive impairment. I'm always like, wait, oh, you can't come along. You can't by yourself. Oh, you can come on in here and answer all my questions, but we expect there to be family on the phone, in the room. I need all of the voices at the table to be a good clinician, and I think that's what success looks like, especially because I'm a psychiatric mental health nurse practitioner that focuses on the behavioral and psychological symptoms of dementia. So I have people that are hallucinating. I have them with fixed beliefs, thinking someone is trying to harm them or kill them. They're dealing with depression. They are dealing with anxiety. And I need to be able to tease out what is anxiety versus agitation versus irritability. So I need all those voices at the table. As an interventionist and someone who is doing work and developing interventions that make sense, I need to have all the people at the table. So Donita Brown, community liaison for my Alzheimer's Association grant. She is a voice. I need voices at the table. There's a community advisory board associated with my grant that has clinicians, individuals living with dementia or mild cognitive impairment, as well as their care partners. It can't be Kalisha coming up with everything. It needs to be for us, by us. And in order to do that and to do that successfully, I need lots of people at the table.
I keep coming back. Thank you, everyone. I keep coming back to something that came up on the first panel, which is time. And each one of you talked about something that takes time, right? It takes time out of the individual caregivers, out of community resources, out of everyone who is surrounding and involved in the care of an individual. And I just wonder, this wasn't part of our panel prep, so I apologize, but just how do we wrap around that concept of the amount of time that providing good care and keeping someone stable and at home, if that's an end goal, while still providing relief, right? And also having them come to the meetings and be part of the conversations and be engaged in all of the steps and all of the transitions and everything. How do we do that in a successful way? And how do we think about addressing that broader issue of how much time this really does take to do well?
May I?
Please.
Is it on? Is it on?
Should be green.
Is it? Oh, it's green now. That's okay. No, I like it. So I think for me, one of the things we do wrong in healthcare is that we rely on the clinician to do too much. There's a whole amazing care team that works with them that can do it. Don't expect me to know where the resources are. That is why we have an amazing social worker. Don't expect me to be the one necessarily triaging the visit. I think part of the problem is we expect the clinician to do more, and they can't check another box. They can't write another thing. They are tapped. But there are so many different points. And actually, my Alzheimer's Association grant is looking at this. Think about your own visit to a primary care provider. There's check-in, there's triage, you see the visit, you see the provider, you check out. There's so many different touch points where if we really wanted to tap into what is going on with that dyad, with that family, before they get to the clinician that day, we really could. We just haven't thought about it. And so I'm trying to think about creative ways to engage other people, because I'm a nurse and I'm a clinician as a nurse practitioner, but I also know there are so many other different people, do you think I'm the one checking in on those medications I prescribed? I'm not. I am sending nurses a message to say, hey, can you call that family in 2 weeks? Can you send them a patient portal message in 2 weeks to see how they're doing? And then all I have to do is follow up and see what that response was from the family. We can't do it all. We really can't. But I think we have not done a good job in educating families about the different roles that everyone in the clinical community has and how then to use everybody to their maximum potential.
I think the other thing is, as we think about evidence-based models and designing tools and interventions, one of the key pieces is designing with caregivers and saying, will you actually use this? What are the pain points we're trying to solve for? One of the interesting things is in the mobile application that I created, it's essentially a free app that exists in the App Store, and families can create a care team for their loved one. They can invite their home health aide, their sibling, their adult day center, whomever is involved in that day-to-day care, so that we don't show up to the doctor's office completely uninformed. When they say, how's your dad been doing? I don't know, my mom takes care of it. That's not a helpful answer. So we have this tool, but of course it's another thing that I'm asking these busy people to use. And I think part of it, the success is co-designing it with them. The second piece is education. Okay, so I had a caregiver come up to me who didn't initially want to partake in my study because she's like, this is another thing. But she's like, but I also feel so trapped at home. I can't leave my husband. I want to go to California and see my family. And I said, well, who else is at home with you? Oh, my adult daughter. Well, what are the barriers to her participation? Oh, she doesn't know when his meds are due. She doesn't know what his schedule is. She doesn't know his routine. Well, there's a tool that you could put that in and she can provide updates so that you don't feel that you're dumping him, but you can actually keep a lens into it. And once people see that there are tools out there that actually can free up their time to do other things, when staff in these adult day centers were spread so thin, see, oh my God, I cannot have to call this family member in the middle of the workday to tell them their loved one had a loose bowel movement. There's ways to do this in a more modern fashion. So I think co-design and education together and partnership are what make things successful.
See people reaching for the mic.
I think I'll just add, I love the idea of co-design and adapting kind of strict randomized control trials to make it scalable is really important and something that I loved learning about when we were doing that. The other thing I'll mention is that caregivers are so time constrained. Obvious statement in this room, family caregivers are, but one of the things that the VA does is has a system to back up caregivers so that if they take part in an intervention, then they are more handoff to a social worker who then gets tailored supports to them. And I think that helps honor their time and really thinks about not just handing them a training that you should work on self-care that doesn't offer relief. It just puts more pressure sometimes, but also what do they really need? Is it respite care so they can go on that trip? And this happens when there is a system of long-term supports, not just a social worker linking you to those supports, because when you don't have an ability to access them, then it's hard to recommend them.
Yeah. I love both of those. Thank you for sharing those. I think my response is that sometimes saving time takes time. And so I think a lot of it is about identifying ways to spend time upfront that may save time in the long run and making sure that we're educating families and other care partners on how to spend that time appropriately to save time in the long run. So we also have a number of digital health interventions that support a lot of shared caregiving, some of which are really to support long-term planning. So thinking about if a family caregiver is the primary caregiver at a certain point in time, what happens when that individual is no longer able to take care of their loved one, and being able to take time to so our digital intervention has all of this information in one place. So we have a bunch of different domains that say, okay, when you're thinking about where your loved one is going to live, what are their goals? Where are they living right now? What do you hope is going to happen? And here are a bunch of potential options, giving folks sort of the material that they need in the moment of planning, and then sort of forcing them in the moment to sort of write something down and make a choice. So then when something bad happens, when there's an acute situation, we have a plan in place, or at least a place to start from. So we're not trying to scramble and connect with resources that may not be available in the moment, spending time in that acute situation where we could have prevented that upfront. So takes time to save time.
I love that.
We're all adding in. I loved all the responses, and all I have to add is, I think there's probably some people from CMS in the room, and I just feel like, geriatric, speaking as a geriatrician, I don't think we can do this work right in a fee-for-service setting. It has to be in a value-based model.
Yeah. So I hear financing changes, put it out there for sure. And the use of technological tools, and really connecting communication across multiple players and doing that proactively as much as possible. So I think that kind of leads us into the next question, which is really identifying opportunities as well as some barriers for really creating this system of care and supporting family caregivers and direct care workers. What would you guys add in terms of, you can speak either to barriers or opportunities, whichever one comes to mind, but what would you guys identify as areas that we should be working on and or magnifying?
So one thing that we really need to do a good job of in both like the research community and amongst entrepreneurs is understanding workflows and people's day-to-day lives. So that's the biggest, I think, both barrier to implementing new things and also a great opportunity. As I said, you don't want to give people extra things. That's a barrier to implementation. But you also need to understand what are their pain points and what are they trying to solve for. And that, I think with in particular in some of the settings that I work with, it's saying we both share this problem and we both need to, let's come up with a way together to fix it. So it goes back to the proposal design as really addressing both the implementation challenges and barriers. I will say in my own experience of trying to embed a mobile application into adult day centers that, by the way, in 2026 still have physical fax machines inside of them. Like, this is the state of long-term care. Getting them to use something is hard. And so what I said to them is, if you've been to one adult day center, you've been to one adult day center. And if you've been one caregiver, we all have different lives, different families, different responsibilities. There's some universalities, but not a ton. And I think going up to them and creating tools that are versatile, flexible, and saying to them, this isn't a randomized control trial. Actually, I'll say you can't. The real world healthcare is not a randomized control perfect setting. So building things that are pragmatic and saying to people, you decide how often you use this. If we have a case management firm that uses our app, their aides in the home record how well a patient slept, how they ate that day, a few other things. They don't record every single thing in that app because that's not fair to anybody, but we came down to the most important things to them and their families that families want to know, that would then save them time, create transparency, bring relief, so that when a caregiver puts somebody or takes advantage of a long-term care support like home care or adult daycare, they feel a sense of transparency and relief that I know what is going on with this person.
That's your mic. I think the only thing I'll add is that many times the families, the clinicians, those of us that are boots on the ground are very invested. It's those that are higher up in administration that often are the ones that are making the decisions that have very little boots on the ground. And so I think that is probably a disconnect. That somehow we need to bring the C-suite and the leadership to where we are, because I don't think it's at the level of the family and the clinicians and the interventionists to make that change. And so part of the reason I'm in this space of both clinician and I guess interventionist, I own that word, is that I am hoping that the research ends up getting where it needs to go in a way that changes practice and policy.
Can you just put a finer point on what you would like C-suites to know about?
Work a day with me. I'm not talking about workflow. Work a day with me. Living my life for 4 hours. I got to do it for 8 or 12 hours and hang out with me. And people we see, and I think that would change things.
And then go home to my house.
Go home. Right? I'm a 3-year-old and a grandmother that's walking on into dementia land. She's coming home with me for a couple hours too. So Just to see him.
Well, I don't have an answer to that. That's $1 million question. There are several $1 million questions that have come up so far. I think we're going to keep going. So I guess I'll start with something that maybe not in this room, but that is in general an underappreciated barrier to having shared care, which is access to paid care. I recently led an evaluation of what I call consumer-directed or self-directed model in the VA, where people who were referred to home care could either hire an agency aide through a tech platform that had trained paid agency aides, or they could have their family caregiver join that platform, receive training, and become an employee and be paid for their care. And this is a really important pilot to evaluate, because 61% of the veterans who took part in the evaluation expressed that they had many times when they needed care and they couldn't get it because there was no agency nearby or an aide canceled on them. So the workforce shortages are really real and shaped everything for them. I think, if the direct care worker isn't there, you can't have a shared care team. But on trust, what we saw is that the term pilot was striking. The veterans who got to choose their own aide, who was often a family member or friend, rated their satisfaction really highly than those who used an agency aide. And one veteran had reported to us in our evaluation that they had 40 different caregivers over several years before the pilot. And that kind of instability makes any shared care relationship nearly impossible. And we know this isn't the fault of the direct care worker. It is the fault of the system that doesn't support them and pay them the value that they are worth. In terms of sustainability, you also need both sides of the dyad to benefit from the care model, right? The caregivers, the term model of care pilot worked because the caregivers were doing this care already, but then they were able to be paid $22 an hour to take on that care. So they were already doing it for free, but that helps improve their financial stability and their sense of being recognized and a part of a system. I think that sustainability is so dependent on being recognized and feeling supported and that you're not doing it alone. And then finally, I'm just kind of building on this, the system also needs to support these care workers. And that was one of the things that came of the pilot, was having this platform and a private agency that worked with the VA to train the caregivers at a time when care needs were also increasing, also seems really critical and was highly valued by the participants in the pilot.
I just have to jump in here as a member of the staff at PHI, where we focus on the direct care workforce. That your point about the stability or the lack of stability in the workforce and the inability for people to find paid care is really a fundamental challenge, right, within our long-term care system, but in terms of what we're even talking about today in shared care, that you cannot develop a model that's based on a partnership and a team when one part of that team is experiencing turnover at very, very high rates and all the other kind of impacts on that workforce. So fundamentally, I would argue that the direct care piece of this and stabilizing that workforce is really a fundamental part of how we can move shared care together. But thank you, Karen. Sorry.
I think one of the strengths of the work that we're all doing on this panel is really making sure that we're developing and testing interventions with others, and making sure that we're not coming up with an idea, trying to implement that idea and assuming that works for everyone else. And I think that is so amazing and so meaningful. I think part of the challenge and barrier for that is creating a system that is really difficult to sustain. I don't know about you, but for some of our digital health tools, we co-design and co-build a bunch of these tools. We make sure that they're working for the folks that we want them to work for. We're measuring our outcomes and seeing that they do, and that's so exciting. But when our projects end and the funding ends and these folks still want to use our tools, well, some of this stuff takes money, right? And so the financial sustainability of some of these interventions, I think, is a huge challenge. So if you have ideas on that, I would love to hear them.
I know. And I will say the one thing caregivers always say, I said, what do you like about the app? That it's free because we already do so much other absolutely great. So it is a challenge, and I think we all need to think in a lens that's entrepreneurial, but I also think the problem we're facing is that we're building tools so that people can work in this broken system. Like me, there's so much communication fragmentation, that's what I'm trying to fix. We need to ultimately fix the system.
And Tom, I'm going to start with you to really kind of, as we kind of set up the rest of the conversation of the day, but to really talk about in practice, what does shared care look like? You do home visits, you're in homes with really medically complex individuals and complex care environments, I'm sure. What from your experience is working in those homes, in those care situations? What's not working, but what would be your vision of like a perfect world?
Thank you. That's a great question. I wish I could answer it. I'll just share a quick story about a patient I actually saw this month and how the paid care worker had such an important impact on their care. This was a homebound patient who was suffering from what was a terminal wound, and I was meeting them early on, so we hadn't really developed the trusting relationship yet. This was my first time meeting them, but the caregiver who was working there had a long time relationship with this patient and with the family and a trusting relationship. And she had actually had a lot of experience with wounds and seen this before. So by me having the conversation with the paid caregiver, the caregiver was then able to coach the family and help them transition to the next steps in care appropriately, rather than sending their loved one into the hospital to have a surgery that would not have worked or prolonged their life. They were able to transition to hospice care and end-of-life care appropriately. And that was just, I thought, a shining example of shared care. So,
How do you, and that sounds amazing, how do you replicate that? How do you, right? Like, how do we have more of those kinds of situations?
I've really been wondering that during the first panel and today, because the relationship between the caregiver and the family is so personal. It may not be the agency, it might just be that specific person and that match. And it's just like the caregiver often just becomes part of the family system and the family team. So it's not like we can just replace the cogs in the wheel and expect it always to work. It's matching. Wish I knew.
Very individual.
But could I just take one moment? I will toot the horn of house calls. I do think, we do know that there are millions of patients, individuals in the United States that are homebound, and not all of them have access to in-home primary care. And these are folks that really don't have any other options. Yeah. So expanding access to home-based primary care would be a part of that solution in the future.
I think I really appreciate that comment about just not being able to replace the cogs in the wheel, because this is a lot of relationship building. And I think that something that helps with that so much is just stepping back and for everyone to listen to each other. I think every member of the caregiving team comes with their own expertise. And so just giving it a second and listening to each other, and again, being grounded in ultimately what that individual wants and needs, it can really support that structure in general, instead of just trying to replace a part of a wheel.
I think you said it perfectly. The only thing I would say is having them, all the care team, all the unpaid caregivers and the paid caregivers in the home, know the plan, create the plan with each other. A lot of times they're not there at the same time, so this is a notion of continuity between the paid aides and the caregivers we need to know more about. But Also, just feeling like neither of them are covering for a system that's failing them. I think I would feel so much happier if we had a system where people really felt supported in their role.
I think just a PSA, if I get one point out, is that caregiving needs to be a team effort. This like falls on one person, right? Shared care means a team, caregiving is a team effort. There's always ends up being one quarterback. I always call him the competent sibling in the family who ends up, I don't know her person. You know, it's really important that everybody is on the same page to prevent these errors, and really that we highlight the expertise and contribution that everybody plays an important role in this. I will just say that in my own family's experience, I had a grandmother who went to adult daycare for 21 years. They recognized things before my mother, who was a physician, did in her that prompted early intervention that allowed her to be at home until she was 100 years old. That is what it takes. It takes a village. It is not one person. It is not one family. It is a village and it is a community. And that is the only way to achieve shared care. And the only way we can do that is if we are all on the same page and all respected for our contribution.
I've never thought about it this way, but it's kind of like matchmaker, right? So similar, I thought about it before, but I have a family story. I have supported this family, I don't know, 5, 6 years. And when I met them, it's a wife, husband, and they have paid caregiver, direct care. The wife was in a nursing home and during assisted living, and during COVID, the husband actually became a CNA so that he could go in and see his wife every day. They don't make love like that. I told my husband, I don't think he loved me. Love her. But anyway, so when I picked them up, she had behaviors. We couldn't keep her at home anymore because of the behaviors related to dementia. So we get her medication stable, and we're going back and forth around, should he take her home? I said, I think you can do it. He was like, it'll just be me and the direct care worker. And I was like, oh, no, that won't work. Because eventually you need to sleep and she needs to go home. Yeah. So we need to work through what we can do. So it was probably months of planning of like this lady actually owned the direct care worker, owned the company, and so she had other direct care workers that could come in. And so I am happy to report they are home. We have taken her off all of her psychotropic medications. She's not on any meds because once they are home, they don't need the medicines that a lot of times we're required to give them when they're in facilities. And they still have a system. He's still working part-time. It works for them. And I think it is a little bit of matchmaking. It is definitely a lot of mutual respect and feeling heard and really being able to have visits. We don't do home care visits, but we do telehealth visits. So the day of, a family can say, can we switch to telehealth? And we will immediately switch them to telehealth. Because again, living with people living with dementia, some days they're just not feeling it and they're not coming to the visit, but they still need to be seen.
That's a great story to end with. Can I borrow the microphone? Thank you. Where's it? I think I started. We're going to transition into Q&A, and I want to turn to the Zoom chat first because we have a few questions, and then we can sort of alternate back and forth. And so the first question is, who holds responsibility for managing care and keeping an eye on overall well-being for a care recipient? I often think it's the family caregiver because of the way the system works and given pressures on clinicians, but I'm not sure that's how it should be. That is a good question.
Everyone holds that responsibility.
You're the start.
Okay. We alluded to the earlier example that when you have a baby, everybody comes and celebrates, right? Because when they say when you have a kid, it takes a village. Well, when you have an older person, it takes a village too. Yes, as I said, there ends up being a family member or somebody in the network that is the quarterback that ends up shouldering that responsibility because, every team, I think, needs a lead. Should have more than one lead, ideally. But the problem is there's a lot of interpersonal dynamics that go into that. I don't want to give up control. I don't want to see it. I don't trust this person. I feel like I can't put them in adult day because I'm dumping them. There's a lot that goes into that. So who should be responsible? Everybody. It's like a neighborhood watch. And I'm not kidding. I have the clients at adult day centers where, you know, the somebody who doesn't have cognitive impairment will say, text the daughter of his friend who does have cognitive impairment, say he ate a great lunch today, you know? And so we're all hands on deck, all eyes on one another. And we really need to revisit this village neighborhood model as we think about this, with, of course, leads who feel prepared and supported to go into this role. If I had one policy solution, it would be that in home economics, I have a middle schooler, if he could learn a little bit about caregiving at that start of that age, because it's such an inevitability in our lives, we would do great things.
And I would just add, well, we talked about the recipient health. I also check in on the care partner's health.
Yeah.
So I'm also like, are you good? Do we need to check in? How are we doing? How are we managing? If I could add one question in the EHR, it would be, are you a caregiver of someone over the age of 65? Because we check in about caregiving under the age of 18. We do very little check-ins in the EHR, at least at Emory, that says, are you a caregiver of someone? And then being able to pinpoint, oh, I need to probably check in on them and make sure they have resources available to them.
She told me I'd use the mic and I just was not listening. My name is Marvell Adams. I serve as CEO of Caregiver Action Network. And yes, you recognize me. So I have a question because I'll forget it. And then a thank you to one of your panelists. But so our organization, Caregiver Action Network, focuses on nationally providing resources, support, guidance to family caregivers. And we do that through our website, and we run the National Caregiver Help Desk, which is the least known resource that's free for caregivers all over the country. But the question is, in what ways do you see gaps in taking your research and your practical insights and scaling them? Because, and I've heard, I think almost all of you touch on the fact that the project ends or the grant funding goes away, or I have this experience with a client or a patient, and it's great for them, but then it's like, it doesn't step up to that next level. So where do you see the gaps, and or what's your magic wand wish, I guess, not how you fix it, but what you wish for? And then the last thing I'll say, and I'll go away, is I am a caregiver. I was a caregiving youth. I didn't know it till I came to work at Caregiver Action Network 3 years ago, but was a caregiver for my mom, long distance in the last couple of years of her life, and the same thing for my brother. But I've seen both sides of it because I am a nursing home administrator by training, even though I handed that part of my career down right before COVID actually started. So my spidey senses. I got my master's at Chapel Hill, and I took a statistics class because I thought I was going to go into policy. And that professor was Courtney. And we've not seen each other since those days. Many years ago.
Yeah, what's was great.
I used to want to
Yes, it was statistics. But Courtney, I belong over to thank you because you were one of the most pivotal people in my life. Because through your class, I realized I did not want to go to college. Because statistics was not my thing. And I took student administration, and that's my career. And supporting caregivers that trying to do the stuff that the researchers would say we should be doing. And two, before you knew me, you chose someone as your teaching assistant named Caroline Moon, who helped me when I got a 49 on the midterm and needed to get a 92 on the final to pass your class. I got a 97. And Caroline and I now have 3 gorgeous kids. He said hello. And thank you.
Wow.
Sorry. So the question.
I truly believe as someone who did scale something up to in a system, and that became a part of clinical practice, that you have to have decision makers to invest in your programs that you come up with. And I was lucky to have that in the VA. But they made it a mandatory training, which you can do in the VA. People say, well, how can you get it outside of the VA? It's such a great training. And so the ways we've been able to do it is just to talk about the costs. What would it take for another system? What would it take for Medicare to a Medicare serving provider or system? What would it take for them to scale it up and do it in their health system? And so the only way, in terms of like, you need investors, and you also need to be able to show what is the cost going to be to another system to scale it up. So that's all I can offer, and then we'll talk offline.
Thank you.
Is there one more response? We have to transition to break. So what I am gonna say is that the panel, I'm sure, is more than willing to share and hug. And answer any questions during our break.